introduced and started by none other than our young Dr. P. Kishan. As you know, P. Kishan has been a model in a way to the young private psychiatrist. When everyone wanted to settle in those days in Hyderabad, he chose a path to start away from the mainstream. He started the Prashanti Hospital almost about 2 decades back. He runs both the IP, OP and specialty clinics. And most interestingly, he has contributed in terms of psychotherapy. He started a psychotherapy group in Karimnagar. He is also interested in another interesting thing for the youngsters sitting behind. All his patients, about say around 60,000 of them, he maintains a clean database of their follow-up, what they are on medication, and sometimes even the brief scales he uses. So that's why Prashanti Hospital should be a model for the youngsters to go and visit and see and work there. He is married, and as usual, his genes are flowing very powerfully. So his children are also on the way to become young psychiatrists. Now, this is my further duty to introduce I would say he was my first senior resident. So I'll start from that story. Dr. Gangadhar has a unique privilege of starting as a resident, being the senior resident, being the lecturer, being the assistant professor, and then the professor, then the superintendent, and finally the director of NIMHANS. I think not many would be able to reach. On the way, he has won his medals. Over the years, his initial years, he has been mentoring, I would say a few hundreds of residents very personally, and few thousands of all the residents who graduated under him. He has taken into passion two important areas. One is the ECT and brain stimulation on one side, and off late, and I would say the age is probably catching in on, yoga seems to be his area of research work. He not only works as a director, but he is a honorary dean for life science of the Yoga University at Bangalore. He is also an adjunct professor of consciousness in the National Institute of Advanced Studies and the president-elect. Apart from that, I think the most important things, almost all the awards in the IPS he has shared, about 25 of them, either as a primary recipient or as a co-recipient. Apart from that, he is still an associate editor of Acta Psychiatrica Scandinavia and in the past, and he is co-editor of the Asian Journal of Psychiatry currently. Apart from that, he is in the editor board of many national and international. He has contributed and probably almost all the centers which can give funding, like ICMR, DST, DBT, Fogati, Wellcome Trust, Ayush, KICIT. He got and he has done the studies, and he had 330, he has to till date 330 scientific articles published in national and international. Now, I can go on and on, but to introduce probably son to you is a kind of a misdemeanor on my part. Without much ado, and I take this as a great opportunity and a great pleasure, I invite Dr. Professor Gangadhar to deliver this oration.
Before the oration, starting the oration, we want to presenting the Prashanti Hospital Karimnagar Oration Award. So please. Garlanding by Dr. Raghuram Reddy Garu. Garlanding. bouquet by Dr. Prasad Rao garu. Gold medal by Dr. Chandrasekhar garu. Certificate shawl by Dr. M.S. Reddy garu. Citation by Dr. Ashok Reddy garu. In honor of Dr. B.N. Gangadhar, we are giving this. Dr. B.N. Gangadhar garu is born on 3rd October 1955. Is a professor. Gangadhar garu graduated from Bangalore Medical College and later completed MD Psychiatry from NIMHANS. He is also a Doctor of Science from Suyasa University, Bangalore, for his research work on yoga and mental health. Having served as a faculty member of NIMHANS from 1982, Professor Gangadhar held the post of Medical Superintendent, Head of the Department of Psychiatry and Dean of Behavioral Sciences. In January 2016, he was elevated to the Covet post of Director of NIMHANS. Professor Gangadhar is a Honorary Dean Life Sciences at Suyasa Yoga University, Bangalore. He is a member of several expert committees, including National Ayush Committee for Integrative Medicine. Among the many awards that he received are the Sir C.V. Raman and Doctor's Day Award. He published over 330 scientific articles in reputed journals. He is presently the co-editor of Asian Journal of Psychiatry and is on the editorial board of national and international journals. Professor Gangadhar is an astute clinician, able administrator, dedicated teacher, and above all, wonderful human being. IPS Telangana State Branch feels honored to give the Prashanti Hospital Karimnagar Oration Award to our esteemed colleague Dr. Professor B.N. Gangadhar at our state conference on 11th June 2016 at Gandhi Medical College, Secunderabad.
At the outset, I must thank all the IPS Telangana friends for inviting me to this oration. I'm quite overwhelmed and emotional, but nonetheless, business has to go on. I congratulate the young team and also the young branch. I understand this is the second meeting that you're going to be holding, and I feel quite honored to be with all of you as part of this oration to share some of my observations and some of the thoughts which could help us to hone our own skills in the area of neuromodulations. Although the title has two parts, electroconvulsive therapy and brain modulations, for purposes of it is just that I cannot start any lecture without having anything on ECT. So it's just that by a habit which doesn't die at all, the ECT got added. But as you can see, I would probably be addressing on other areas of brain stimulation which does not include convulsions. So there are several things, although I may limit today to some of the things that have had some role to play in our day-to-day clinical practice. Emphasis is more on that, but less on some of those things which we need to know some theory though. So obviously the ECT has to be summarized, and this is the summary of what development that have happened on ECT. We obviously need to look for an alternative to ECT for various reasons which people have been talking about. One of them was, one alternative was this magnetic seizure therapy. Again, seizure is there, but this form of therapy produced fewer adverse effects, and possibly could replace ECT, but the cost of the machine is so prohibitive, it is unlikely that maybe in the coming decades this would replace the ECT machine. But yet we have other forms of brain modulation, of which I would probably be dealing more about two of them, transcranial magnetic stimulation and the transcranial direct current stimulation. Both of them have now come to be practiced by many of us here. I'm sure many of you are already using TDCS, just to reflect and the clinical development that have happened in this area. TMS, transcranial magnetic stimulation, has two components. One is investigational, the other one is therapeutic. In fact, it began to be introduced as an investigational tool to measure the central motor conduction. They tested people with demyelinating diseases and a host of other neurological disorders. A magnetic stimulus was placed here, and you would record the EMG potential here and another potential at the back of the neck, so that they would know how much is the time that within the brain it has to it takes to conduct. And recovery from MS would mean that this conduction gets faster and faster, and they would use this for monitoring. Although this is not the best way of monitoring, and most neurologists found it to be not as reliable a clinical indicator. But that some brain can be stimulated without having to use electricity was some charm that it obtained, and it went on to be used for various other investigational purposes. And now we have TMS being applied largely for therapeutic purposes, which attracts all of us here. Okay, would the magnetic stimulus itself would not directly stimulate the tissue. Magnetic stimulus, whenever the magnetic waves are interrupted by any conducting tissue or a conducting material, at that point of time the electricity is generated, and that electricity in turn changes the membrane potential, and it goes on. So it is actually an indirect form of electrical generation deep in the brain. Electricity itself, had it been applied to the scalp, good amount of it would be lost, wouldn't be conducted. Whereas the magnetic field can pass through the skull. Skull is not opaque, not insulated, it doesn't insulate the magnetic field. So we get the magnetic field easily passing through the skull cap, and so we are able to stimulate the tissue. Today we have the TMS machines which can stimulate about 2.5 centimeters below the place where we apply, but deep TMS coils have begun to be made, and one of them has been used in the stimulation for the magnetic seizure therapy. what does the TMS machine produce? It produces about 1.5 to 2 Tesla. Different machines have different energy levels. 1.5 to 2 Tesla is the magnetic field it generates, and the amount of the magnetic energy which is used is about what we would use in an ordinary loudspeaker. How does the TMS work? Before I go on to where it works, there are several hypotheses which have been examined, and some of which actually have some evidence in biological literature. Plasticity, it can improve the neurotropic factors. People have shown elevations in brain-derived neurotropic factor. It improves the blood flow, or at least changes the blood flow in different parts of the brain, depending on what is the nature of the TMS that you use. Of course, it changes the metabolism and a host of other neurophysiological activities. Connectivity has been across the brain is supposed to get better, and people have used the TMS to get the connectivity better and for enhancing cognition and a couple of other neurological states. Also, people have used TMS as a therapeutic ingredient. Where do you stimulate when you apply the TMS on the brain? You use a point which is defined in relation to the standard 10-20 system, and 10-20 system is something that we are already familiar. One of the popular places is the dorsolateral prefrontal cortex, and that is in between the FZ and the F7, midpoint of that, and also a midpoint between FP1 and C3, that point on the left side. Corresponding one on the right side also is there, but more often than not, people use the left dorsolateral prefrontal cortex for stimulation for treatment of depression. Then you also use the supplementary motor area, which is used for deciding where, how intense is my stimulus. I'll come to that little later. This stimulates the motor area, and you get the twitches in your thumb if you stimulate that area, and that is what was used earlier for measuring the central motor conduction. And you have the temporoparietal junction, which is a point where people use for stimulating to reduce the persistent auditory hallucinations. Other than these, you also have the orbitofrontal area, which people are using it for improving cognition, although final answer has not been said in this. So you have single versus repeated RTMS. Single is often used for investigative purposes. You put one pulse, you catch the stimulus response here, and then measure the conduction. Of course, there are many other forms of measurement that people have used the single pulses for, but for our purposes, it is RTMS, which is either slow, lesser than 1 hertz, or faster, is more than 5 pulses, 5 stimuli per second. The lesser than 1 would probably make inhibitions. The more than 5 would actually produce activation of the given cortex where you are going to be stimulating, and each is used differentially for purposes of either subduing your cortex or actually enhancing the cortical function. So there are other variables that you may want to apply your mind when you are talking of TMS. The frequency at which the pulses are given, I already said, less than 1 pulse per second would be inhibitory or slow TMS, and more than 5, and you can go on. And you have a train of stimuli. So you probably give about 10 stimuli or 20 stimuli in one train, and there is an inter-train space. You are not going to be giving any stimulus at all. And then a whole session would last for maybe about 20 such trains or 30 such trains, depending on patient to patient, clinician to clinician, condition to condition, and so on and so forth. So these are the variables that you need to remember. There is nothing called as a cumulative magnetic dose people are talking about today. People are talking about number of pulses that people have used for this given individual over a given session. 20,000 pulses, 15,000 pulses, unlike in ECT where you put all together and you say some 30 millicoulomb or 100 millicoulomb and so on. Stimulus strength. in ECT, of course, we have 800 milliamperes and such definitions are there. In TMS, you make a stimulus measurement as a proportion to the maximum magnetic field that that given machine produces. Until today, I have challenged a lot of ECT, a lot of TMS machine manufacturers. Can't you define what Tesla that your machine gives? Each machine keeps varying. Interestingly, I was told, although it remains to be confirmed, even within the same company, same brand, machine to machine variation in the Tesla value could happen. I don't know if any physicists would approve this or not, but I have heard this. I don't want to be quoted because it is just a hearsay. So for that reason, what they say is you give the amplitude or the magnetic field in percentages of that machine's maximum output. Next, as far as our clinical application is concerned, we measure the threshold by giving the pulses in that central vertex portion and then record our thumb movement stimulus. The threshold at which we will get the stimulus is called as the motor threshold, and the motor threshold is defined by at least 50% of the stimuli produce the twitches. Here again, there are many determinants of this motor threshold. I am not going into those details. So this again is a fairly variable value, but most TMS researchers use a stimulus that is in relation to your motor threshold. So there are two relations that come up: relation to the maximum output of that TMS machine, 30%, 40%, 50%, and from that value of the threshold, you take a percentage for giving the stimulus. People say same as 100% of that of the motor threshold, 120% of the motor threshold, or 80% of the motor threshold, it goes on. There are of course risks of giving higher dosage of the stimulus. It could theoretically produce a seizure. So various TMS subtypes, like I said already, inhibitory and excitatory. Faster ones are excitatory and slower ones are inhibitory. Other models have been talked about, and we really haven't found final answer to different other types of stimuli other than inhibitory and excitatory, which have been fairly well confirmed. Other forms of stimuli are not really well described. Here, of course, a prototype model of 40 pulses. You give about 30 seconds gap, give another 40 pulses, and it go on. A train in the entire session can have about 20 or 30 such trains, and you end up giving about 5,000 to 10,000 pulses eventually to the individual. Now I come back to clinical application. This is about the basics of the TMS, stimulus, parameters, how you stimulate. So once you determine the threshold, a percentage of the threshold is used for stimulating the individual. Most researchers in depression or even in that of schizophrenia have used 100%, and some of them have used 110%, although I would recommend keep it at 100% or even at 90% of the motor threshold value to be used for the stimulus. The argument here is your right side is hyperfunctional and the left side is hypofunctional, and so you have to stimulate one of the left dorsolateral prefrontal cortex with multiple stimuli, or alternatively stimulate the right side with a fewer stimuli, or both. Although that both is not something that's very popular, one of our colleagues wants to research that you stimulate faster on one side at the same time reduce or infrequent stimuli on the other side, you would probably going to get the bilateral TMS could be more potent than the unilateral TMS, but the work is still not complete. Like I said, 80 to 120% of the dose of the resting motor threshold, 5 to 20, and then it goes on. So whatever as the FDA has approved, I have shown here. The left side, 120% FDA, although I am recommending 100%. 75 trains for a period of 5 days, one session per day, 5 days in a week, 2 to 4 weeks supposed to give the best results in terms of TMS. This is what the FDA says. Although the clinical trials are not all that promising. There are not many well conducted trials. There are some meta-analysis which have been done, and what is important is the effect sizes are only modest. And if you look at patients who are treatment refractory treated with TMS, the effect sizes even further drop. And when you compare it with electroconvulsive therapy, the ECT fares much better than TMS, and so you probably have no great benefit of using TMS, given that the expensive cost of the machine is very expensive. So people have looked at left high frequency RTMS versus right low frequency RTMS, and then they have found that the left high frequency and the other one are about the same, with a marginal benefit for the left DLPFC being better. So left DLPFC, this is it. What the overall benefits, only about 30% of them get better. As against remission rates, it is even smaller, 20%. So there is not something very exciting as far as using RTMS in treating depression. Adding TMS to ongoing antidepressants right from the day one or at later points of time, there seems to be some benefit of adding RTMS. So they are saying, okay, RTMS is not effective in depression, add RTMS to ongoing antidepressants, you would probably be better off than merely giving antidepressant drugs. RTMS and ECT, like I said, there are good data to show that ECT is better than RTMS. This is about depression. Now we have RTMS in hallucinations. Here again, like I said, the temporoparietal junction is the place where we choose, and then you choose a slow RTMS. This is the place where the cortex is hyperactive, and so it is producing more stimuli and causing persistent auditory hallucinations, and antipsychotics including clozapine. Even sometimes ECT did not work, RTMS seemed to have worked. The initial studies have shown RTMS having worked, and people are now going into using TDCS. I'll be coming to that a little later. The results seem promising in a way, given that these people have not responded to many treatments. There are several RCTs, and people have done a meta-analysis, and the weighted effect size is not something very striking, 0.21. Most clinicians will simply discard that effect size, but yet clinicians have been using, and we also did use a person, expose a person with RTMS, persistent auditory hallucination, and that is the only thing that worked for this individual. And the person maintained it for 6 months. Now it's close to a year. He comes periodically, gets an RTMS session, and then goes back, and for weeks together is free of auditory hallucinations. Negative symptoms, the results are nearly negative. There is no benefit of giving RTMS to benefit negative symptoms, although there is a small benefit people have claimed. The meta-analysis seems to favor using RTMS for negative symptoms, but in our own clinical practice, we have not had it so well. Cognitive symptoms is another bugbear in managing schizophrenia. Whether TMS would benefit cognitive symptoms, again the results are quite equivocal. There is no foolproof reason why you should be using RTMS. There are of course a lot of psychological test findings which show working memory gets better, and the theory of mind tests get better. Some data to show even social cognition seems to get better with RTMS in patients with schizophrenia, but would it translate into real clinical benefit, which has not been very positive, very promising. Whether the functional status of the individual would it get better, we still have no answer to that effect. RTMS, like I said, connectivity story. there are deeper structures which cannot be activated by RTMS. For example, here the hippocampus, it's quite deep. RTMS won't work. But we know that hippocampus and the parietal cortex, there are a lot of connections. In fact, most of the inputs to hippocampus go from the parietal cortex. And it's quite superficial, and someone thought that you go on stimulating the parietal cortex, the connectivity improves and the hippocampus gets more activated. And if the hippocampus being more activated means better memory functions. And he in fact did find that this connectivity gets better, hippocampus to parietal connectivity is enhanced, which is now measurable using several methods in the MR imaging analysis. And not only that, he was able to demonstrate that some functional changes in terms of changes in the memory performance getting better in these individuals had they been stimulated with the parietal cortex with the TMS, and that's indirectly activating the hippocampus, which in turn shows clinical effects or at least behavioral effects, performing memory functions better. This approach for clinical translation is yet to be done. This is on human experimental subjects. This is not on clinical population. It's a preclinical study, but yet it has been fairly well cited, appearing in the journal Science, which has had a very good impact in terms of reading further research, translating it into clinical application. Yet we don't have a final answer on this matter. We have, of course, people have tried TMS on OCD. Our own colleague, Dr. Shamsundar, has done a randomized clinical trial, and the results have not been promising. So OCD is not. This is a summary slide. All these slides will be available here on the computer. For those of you who want to use this, are all available. This gives where all the benefits one can obtain with transcranial magnetic stimulation. Depression, yes. Persistent auditory hallucinations, yes. Other conditions, plus minus. We need to perhaps do more research. There are, of course, a host of other disorders which have been tested out using high frequency on the right side for mania. Case reports. There are many other conditions like mania, catatonia, you have anorexia nervosa, you have substance use disorders. Neurologists have used in migraine, various movement disorders, have found variable benefits. Neurologists don't widely use RTMS as a therapeutic ingredient at this point of time. Some movement disorder clinics still offer RTMS for purposes of involuntary movement disorders. Most of anxiety disorders, where again the benefits have not been good enough, it can't be recommended for correct clinical use. My teacher, senior colleague, Dr. Jankaramaya used to say, there is no treatment that can be effective without having side effects. If there is any claim that there are no side effects, it's likely that the treatment has no effects either. So RTMS, of course, has a lot of side effects. Some of them, most of them are very benign. Seizure is one side effect that you need to get yourself worried and make sure that this individual does not have history of seizure disorder, does not have a family history of seizure in the first degree relatives, and young subjects are more likely to have a risk of seizure as a side effect. In fact, we had one individual who has had a seizure as part of this procedure. There are guidelines that are available today and you need to follow. Both these guidelines are available free on the internet, and I'm sure you can get most of this information. One precaution that I tell everybody is that make sure that this individual's history of seizures have been thoroughly excluded before you go and take this individual into RTMS. And those of us who are carrying our credit cards, etc., don't stay closer to the RTMS machine. And of course, these days the cards are gotten better. Earlier credit cards used to get wiped out, and we couldn't use. One of our friends had this difficulty after entering the RTMS session. He was there with us, and while going back, he got panicked because his credit card didn't work, and somebody told him that this could happen. But today's credit cards are fairly safe. You don't have to get really worried about it. So where do we go from this level of TMS in future? You have a neuronavigation method of finding the right place to give that stimulus, and we have started using it, but I know it is very prohibitive and most people may not be able to afford in clinical practice. There are different forms of stimuli, the theta burst, the quadri pulse stimulation. Deep RTMS, again a very expensive coil, and we have the simultaneous bilateral stimulation. Again, it is going to be very expensive in terms of the machine, and of course the magnetic seizure therapy, to which I alluded to earlier. And you have transcranial alternative current stimulation, which will come to a little later when I am talking of the TDCS. You have, of course, this low field magnetic stimulation. This low field magnetic stimulation report came as recently as about 2 years ago in the biological psychiatry, promising results. In the 80s, those of you who might have heard in Chennai, then Madras, this magnetic therapy used to be given. I did as a PG. My teacher, Dr. R.L. Kapoor, asked me to go and visit this place and come back. We went and visited. It was a very crude way of having a magnetic, and wherever there is a pain, your limb pain, you could put that limb inside, then there is to be low field magnetic activity, and they say the pain is gone. And if the pain is in the back, the person would be made to sit inside that huge container. And to us, that time it looked very crude, and we thought it was all merely placebo. We thought it was all some gimmick, etc., etc. I came back and said the same thing to Dr. Kapoor. Kapoor laughed and said, no, 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 you should do some more work on that. But then we had never heard of anything called as magnetic stimulation in neuroscience or psychiatry at all. But there was an early, not even early, exactly in 1980, which when he asked me to go and visit this place as a student. But then we know the TMS or magnetic stimulation has gone on, and the same low field magnetic stimulation has come up. Of course, we have today magnetic ultrasound, about which I will be quickly alluding to. So it looks like it stopped. Okay, there are, I don't know, this whole thing hasn't gotten downloaded in when you don't have to worry. I have to probably stop here. The TDCS slides seem to have disappeared from this whole thing, and stopped at the future direction. Whoever edited must have thought at this point of time my lecture ends, and when downloading the slides, he must have re-edited the whole slide operations. Don't have to bother. Let me see if it is in the back. I will try that, and if there is time.
Beautiful inaugural oration, I would say. In a way, it is Dr. Gangadhar's life. He started his MD thesis, I believe, with ECT, and then he continued his work in the brain stimulation, and probably, as his last slide has wonderfully summarized, in the yoga also he's trying to look for the evidence like a true scientist. Like a good mentor, he has shown us his work. I'm sure a lot of youngsters are stimulated. Thank you, Gangadhar, for the wonderful, wonderful lecture. We would cherish, I would personally cherish being the chair for this session. Thank you. With Kishan. And of course, though Gangadhar said that there are no questions, Gangadhar is available with us for the day, and he's always ready to answer your questions during later time.
To conclude the session, I'm expressing my thanks to IPS Telangana State Branch members as well as the seniors who accepted the Prashanthi Hospital proposal for the oration. At the same time, thanks to organizing committee, Dr. Ashok Reddy and Dr. Om Prakash for giving the opportunity to chair the first session of oration. Then good news to my young brothers of Karimnagar and Nizamabad. I got our TMS machine in Karimnagar, but not yet started. I think with Gangadhar sir, this month I am going to start. Thank you. Thank you very much.
Now I request Dr. Umashankar sir to give the certificate of oration to Gangadhar sir. Now I request the chairperson to give the mementos to Dr. Gangadhar sir. Doc
He will do that. Oh, thank you.
and a memento to Dr. Kishan sir. And I request Dr. Gangadhar sir to give a memento to Prasad.